Okay, good morning, everybody. Thank you for coming. I'd like to welcome you this morning to a very special edition of our Graham Dunn Seminar series. Obviously, it is all here to celebrate Carlo's career, but we've also done a very special edition of Graham Dunn. Matt and I co-organised this seminar series, and then Hui has very kindly stepped in and helped organise. So if it all goes well, I've done everything. If it doesn't, let's blame these two. So Centre for Biostatistics runs 2 seminars per year, named after our late founder, Professor Graham Dunn. Graham was hugely instrumental in the careers of many members of our centre and countless others before that, and I know he will be delighted to see how that the centre has gone from strength to strength. At the moment, we seem to have more PhD students and postgraduate students than we've ever had before, and in fact, we are bursting at the seams and starting to run out of desks. Graham's career was dedicated to the design analysis of trials of complex interventions, particularly those in the field of mental health. Causal inference was at the heart of everything that he did, and to heart his pioneering work in the use of instrumental variables to explore the causal effects of dose, therapist, and other moderators. So it's only fitting that we use the Graham Dunn Seminar series to focus on the work of Carlo Berzuini. So that's the purpose here today, is to celebrate Carlo's career. I know that you're going to hear much about Carlo throughout the course of the day, his career, his work, his mentorship, his friendship, and others know about that much better than me, so I'm not going to say very much. The topics today have been chosen very carefully to reflect Carlo's work and provoke a reflection on the current trends in the application of artificial intelligence in healthcare. Carlo has invited a mix of collaborators that includes both experts in causality and healthcare researchers who work on the interface between medicine and maths. The clear aim here is to demonstrate real-world examples of the relationship between AI and causality. So, you can see the program here. We're starting off with Dawid and Carlo, then most importantly, lunch, which will be served just outside. Then we have Dawid and Hiren, then coffee, and then Hui, and then hopefully both Andy and Jamie will be speaking to you by various means. We are recording, so if you, I don't think you'll see anybody's face, but if you do say a question in person, bear in mind that that will be recorded and it will be shared more widely than the people here. So talk to us if there's any problems with that. And finally, I guess most importantly, we aim to finish our celebrations with a trip to the pub to celebrate Carlo's retirement. So that will be in the Crowbar from the end of this session onwards. I've seen Carlo talk many times before, and I know that this programme will be informative and entertaining. I also expect there may be some fluidity in the timings, but we'll try as far as possible to keep things to plan. I believe that Carlo is going to set us off by introducing our first speaker.
Philip, maybe he's connected. I don't know.
Yes, he's
Philip, are you there?
I'm here, Carlo.
Oh, hi.
Oh.
Before meeting Philip in person, I met his papers. I think it was in 1976. I read a paper by Philip Dawid on the properties of diagnostic distributions. Maybe it was 1977, or I think it was 76. And I liked the paper. And later on, I found further paper by Philip, and I realized that there was something special in this paper, something I liked, and it was a very strong theoretical framework and rigorous way of writing papers, almost metallic, but at the same time, there was a philosophical grade. The concepts he expounded were connected with very general and lucidly written principles, and so basically, before meeting him, I was very much fascinated by his papers. And then I got in contact with him, and it was at the beginning of this century. That was the decade of causal inference, and Philip was one of those who opened my eyes to causality. Not only my eyes, he opened the eyes of many people. He's one of those who played a major role in breaking the barrier that, may I say, the statistical community raised against causality. He invented a new framework, a new justification for causality, which you will hear about from him today. And yes, one of the things I cherish mostly in my career is the collaboration with him I had with him, and obviously the friendship. Philip, thank you very much for your intervention. I leave you on the stage.
Thank you very much. You've been a very good friend, a very strong colleague for very, very many years. We've had very good times together. I'm delighted to be able to contribute to this day in honor of your retirement, and only sorry that I can't be with you in person, and in particular to join the events in the pub at the end of the day. However, I'll do my little bit, and I will stay online and look forward very much to hearing all the other contributions that there are going to be. Okay, you see my full screen?
Yeah. Yes.
Splendid. Okay, so there's going to be, I think, a number of talks today which involve the idea of a causal graph, which is a representation of a causal process. So I'm going to take a very high-level abstract view to start off and ask the rather crucial question, what is a causal graph? And related to that, how should we use it? And I'm going to say that there are various kinds of graph that can represent causality, but just for the sake of simplicity, I'm going to restrict to the most common one, which is a directed acyclic graph. And a simple example of such a directed acyclic graph is one which can be used to represent the problem of using an instrumental variable. So forget that title for the moment, just look at the graph. You'll see it contains nodes, 4 nodes, U, Z, X, and Y, and arrows between them, directed arrows. So it's a directed graph. It has nodes, which are X, Y, Z, and U, and I've given them names, which would perhaps be used if you were thinking about modeling a real instrumental variable problem, that X is something which is maybe an exposure or cause you're interested in, Y is an effect you're interested in, Z is what's called an instrumental variable, we'll come back to that later, and U is just some unmeasured, unobserved variables. So what's this all about? So what is a directed acyclic graph? As you've seen, it contains various nodes, and each node represents a random variable of interest. It may be observed, or it may be unobserved. There are arrows in the picture, and a big question we'll come back to is, what on earth do they represent? It's not obvious to start with. Because we're dealing with directed acyclic graphs, we'll restrict to the case where there aren't any loops. In other words, you can't return to your starting point by following the arrows. There are generalizations which don't require that. Right, so what is this? Well, it's not just a pretty picture. Oh, it is a pretty picture, but it's more than that. It's meant to say something about the relationships between the variables in the problem that are represented in the nodes. So then we have to ask, what is it meant to say? And how is it meant to say it? Those are 2 extremely important questions. And what I'm going to point out is that there are several ways of addressing those two questions, and they lead to different understandings of what a causal DAG is and what it can be used for. So let's go to the most basic and simplest case first, what I call a probabilistic DAG. So what is that saying? What is it meant to say? It's meant to say something about the probabilistic conditional independence relationships between the variables represented in the DAG. So that's the what. And the how? Well, there is actually a very clear and well-described explicit procedure. There are two variations which are equivalent. One's due to Pearl and others called deseparation, another one called moralization, but they're essentially the same. And they give you a way of looking at the graph and understanding what it is saying is conditionally independent of what given what. And it's explicit. If I had more time, I would actually explain in more detail. Many of you will understand this already, but just take it for granted that we do have a very clear and explicit way of querying the graph to see what it is saying about conditional independence properties. Now, that's what the graph is saying, but one thing I want to point out very strongly about this is you have to make a difference between what the graph is saying and what the world is doing. Is the world properly represented by your graph? It may be, it may not be. In this particular case, if we can get lots of data on the variables and therefore estimate their joint probability distribution, it would in principle be possible to test the conditional independences which are represented, and therefore to test whether or not the DAG is actually saying what's going on in the world. It may or may not be a correct representation. That's important. So, excuse me a moment. So what is this graph saying in terms of conditional independence? It's saying exactly two things. It's saying the variables u and z are marginally independent. So this is the independence symbol. U is independent of z. And it is saying that y is independent of z, conditional on any values that u and x may take. So that's if you look at the picture and look at the algebra, it's not the least bit obvious that they're related at all. And it's only because we have this explicit way of reading conditional independences off the graph, which I haven't actually told you in detail about, but take it for granted, take it from me, that these are the conditional independences, exactly those which are represented in the graph. One important point to make is that the same conditional independence statements, we've got two there, the same collection of conditional independence statements may be represented in more than one way by more than one graph. Or alternatively, there may be no graph whatsoever that represents them. When there's more than one graph that represents the same conditional independence statements, we say those graphs are Markov equivalent. So if you look at the string ACB and all the different ways of putting arrows in different directions between those in that string, it turns out that the top three are all Markov equivalent. There's nothing to choose between them. They are all different but equivalent ways of representing the conditional independence property that A is independent of B conditional on C. If you discover that that is true in your data, you are free to use any one of these three graphs to express that property. The final graph, where the two arrows point inwards to C, actually says something different. What that says is that marginally, but not conditionally on C, A and B are independent. And you can test that too. So it may be that one of these three represents your data. It may be that this represents your data, or it may very well be that none of them represent your data. So let's take a high-level look at that and see. I think when I say points to remember, I think what I want to realize is what the graph does not say as much as anything, what it does say and what it doesn't say. So such a graph is just a pretty picture which is no more and no less than a way of representing a collection of conditional independence relationships. It's not just a pretty picture because it has very clear semantics, what I call separation, which enable us to see exactly how conditional independence relationships are represented by the graph and what they are. And you can easily query the graph to see whether a particular conditional independence relationship you are considering is or is not represented by the graph. As I mentioned earlier, any particular collection of conditional independence relationships may be represented in several different ways by different graphs, or maybe none. But we are dealing with a case where there is at least one representation, although other cases are certainly of interest. One thing is very important, what it does not say. It does not say what the arrows mean. The arrows are, as I said, used in a very indirect way through this deseparation criterion to show how you can represent conditional independence in the graph. And one way, obviously, of seeing that how the arrows can't mean anything is an arrow has a beginning and an end. It has a direction. But a conditional independence relationship or marginal independence, which says X is independent of Y, you could equally write that as Y is independent of X. There's no directionality involved. So the actual arrows don't mean a thing. They just have, they're like, I think of them as like construction lines or like contour lines on a map. You won't see them on the ground. And a very important thing is that I haven't said anything about causality, or I've only talked about probabilistic conditional independence properties. A probabilistic DAG says nothing whatsoever about causality. Well, we're talking about causality today, so we can't let that go for long, but let's be careful. And that brings us to something which I call reification. Reification is making something which is fictitious and pretending is real. So the arrows are just parts of a rather indirect representation of conditional independence. Nevertheless, it's very tempting to think that arrow has some sort of intrinsic meaning in the real world. So what might it be? Well, one common understanding is that an arrow somehow represents cause and effect, and we'll discuss that in more detail in a moment. But I do want to point out that there's nothing in the structure or semantics of what I call the probabilistic DAG that has anything to do with causality, and certainly does not justify us understanding an arrow as representing cause and effect. And if we want to do that, we have to move away from the probabilistic interpretation and have an entirely different interpretation of the DAG. So what might that be? Well, the sort of thing people might say is that when we see an arrow, we regard that if an arrow from X goes from X to Y, that means that X is a direct cause of Y. And if we just follow a directed path from X to Y, in some sense, that's a causal pathway by which X directly or indirectly influences Y. But we've introduced some causal terms here. And if this representation is going to be any help, we have to understand what those terms mean to us. So think about that. The terms in yellow are causal terms, and we have to understand, in order to understand what the graph is saying, we first of all have to understand what those terms mean to us. Here's something which we might call a causal DAG. This is the kind of thing you see in the literature in many different places. So a causal DAG is a DAG in which, if we don't have an arrow from one node to another, it means there's no direct causal effect, but that has to be understood relative to the other variables which are represented. And if we have variables which have a common cause, then that common cause has to be represented. But again, if we're going to think of the DAGs representing these causal concepts, we have to understand what we mean by those causal concepts. What do they mean? And I don't think much attention is often given to that rather important question. So let's go back to the instrumental variable graph, which previously I just used as a representation of some probabilistic conditional independencies. But it might be interpreted in the following causal terms. And this again is the sort of thing you would see in the literature, that we understand that Z has a direct causal effect on X. Remember, X is the thing who's the exposure or putative cause we're interested in, how it affects Y. But Z, we can't maybe manipulate it directly, but we have something called Z which can help us in manipulating X. X and Y have U as a common parent, so that's regarded as a common cause. We can't go from Z to Y except by going through X, so we say Z affects the outcome of Y only through its effect on X, and there's nothing which joins Z directly to Y, so Z does not share common causes with Y. And I ask again, what do these causal terms mean? Because if you don't know what they mean, you don't know whether that's an appropriate representation of your problem or not. Another thing which you'll see all over the place now, and is very important, but also philosophically slightly fishy, I think, is the whole enterprise of causal discovery, which operates something like this. You gather observational data on a system, you observe lots of variables, and from those, you infer their probabilistic conditional independence properties. And with luck, you can represent them by one or possibly more than one DAG. So you fit a directed acyclic graph model to represent the probabilistic conditional independences. That's fine, that's what it does. But then you reify it, you jump to a completely different interpretation, and you think of that as a causal graph, which represents all those rather vague causal concepts, which I've already introduced. And there are a lot of questions you can ask about that. When is it meaningful? What does it mean? When is it trustworthy? Can it be formalized? What assumptions are required? Can they be justified? The whole jump from one interpretation of a DAG to a completely different interpretation of the DAG is a very big leap and requires a lot of thought and care. And I think one of the main points I want you to bear in mind for all this is the difference between the map and the terrain which you're mapping. So bear very clearly in mind that your DAG is something which represents a real problem. The problem may be a problem which has probabilistic properties, as clearly understood. It may be a problem which has causal properties, which may be clearly or less clearly understood, but it is only a representation of those properties which are out there in the world. And so the most important takeaway from that is, if you've got a DAG, you can't use it to define causal properties. If you think you've got a causal DAG, the DAG has to represent properties which are already out there in some form or other. So you've got to have prior external understanding of what you mean by those causal properties. What is a direct cause? What does it mean? What a common cause mean? What's the causal pathway? What are those things? Unless you really understand that in a way which makes no reference to DAGs, then you can't ask, is your DAG an appropriate representation? And if you can do that, and there's different ways of doing that. If you can do that, then you can start thinking about how you might represent them in a DAG. And what are the semantics whereby the DAG actually says something about those causal terms? And how would you test that? So where are we? Things are looking a bit fuzzy because we've got the same object, the DAG, and we've got more than one interpretation of it. There could be a probabilistic DAG, it could be a causal DAG, whatever that is, it's still a bit vague. And that's a bit ambiguous and confusing. So, and particularly because the same object can represent both probabilistic and a causal DAG, there is tremendous temptation to jump from one interpretation to another, whereas in fact they're doing extremely different jobs. And it's very ambiguous and confusing to use the identical representation with different meanings. As for the causal interpretation, I've asked you to consider carefully what you might mean by the causal terms which you think you're representing. And if you start thinking about those without thinking about how you put them in a DAG, which you've got to do before you put them in a DAG, you'll find that it's all rather obscure and rather pretty hard to formalize. So where are we? How are we going to solve those problems? And in particular, how are we going to do something a bit less informal and obscure when it comes to representing causality in a DAG? And I found out what we need, and what a lot of the discussion of causal DAGs does not seem to have, is a clear formal language with very explicit semantics by which we can describe and manipulate causal properties by means of their representation in a DAG. I say by means of the representation in a DAG, as a matter of fact, we can do that even without DAG representations. So I want to have a formal language by which I can talk about causality, which can then be put into a DAG if I so wish. And we have, for that, I have essentially two single fundamental ideas. First of all, I haven't mentioned this, but I still, probability, as we all, I hope we understand well enough for all the arguments about its philosophy, what probability is. So we're still building probabilistic models. But also there's an undefined primitive term of intervention, what it means for an external agent to get into a system and pull a lever or turn a knob or something and actually intervene and set a particular variable to a particular value. And we understand causality as how the system responds to such an intervention. So that there's no mention of a graphical representation here, just the idea that we have a system and we could kick it and then we see what it does. And that is a matter of cause and effect. And it might or might not be related to how it behaves if we don't kick it. But it may or may not be possible to do the kicking, the tweaking, the twiddling the knob. And it's often the case that we can't experiment and intervene in such a way, but we can gather data from from an unkicked system, understood which we'll call idle. And as a matter of logic, there may be no connection whatsoever between what the system does when you're just looking at it and what the system does when you give it a kick. But causal inference relies on, if you're going to do inference, what you want to do is get your data from your undisturbed idle regime and use it to make inferences about causality, which is to say inferences about how the system would respond if you were to kick it. And as you can't kick it, what you've got to do is insert assumptions about how that's related. So unless you can put in assumptions which say certain aspects of the idle regime can tell you something about aspects of the kicked regime, then you're not going to get anywhere. So causal inference cannot proceed without making assumptions which typically cannot be empirically verified. You want to assume connections between the undisturbed regime and the intervened regime. You can't kick it and observe what happens when you kick it. So you typically can't, I mean, on occasion you can, but most of the time you can't. And so you have to make unverifiable assumptions, but doesn't mean to say that they shouldn't be justifiable. Okay, so that's what we need to do to express causal inference in a formal way. But we have to get the language right. So what we're going to do is try and present a language by which such assumptions can be explained, represented, and manipulated. And I told you that causality is about the effect of interventions in a system. So consider a particular variable x within the system, and I'm going to add a new variable I call fx. And it has a number of possible values. It basically describes how x is intervened, how its value comes about. So if little x is a possible value of the variable x, then fx equals little x. The understanding, what that means is you're talking about the intervened regime where you have manipulated the variable x to a value x by some external intervention. And they have one of those for every possible value of x. And there's a final value, which we denote by the empty set, but we read it as idle, which says you don't kick it at all. That is what you look at in the undisturbed system. And depending on whether I'm observing it or setting it to a particular value, that may change all sorts of things in the system. And we're modeling everything by probability. So for any value of this intervention variable f sub x, I will have a joint distribution for all the interesting variables in the problem. And different settings of the different intervention variables in the problem will lead to different joint distributions. So that means that these variables I've introduced aren't random variables. They're like parameters in a statistical model which determine the distribution you're talking about. They're non-stochastic variables, but they describe the distribution. We don't make many hard and fast assumptions, but one which is relevant, although it can be dropped, is that if I intervene to set x to little x, then actually x will take the value little x. You can have more general interventions which are much more less focused kicks, shall we say, which change the number of things at once. But we'll deal with the case of what's called a perfect intervention. So if you set x to little x, it will take the value little x, but it says nothing whatsoever about what happens to other variables in the problem. So that's it. That's all there is. We've got a lot of different distributions representing different regimes, kicked or idle. And that doesn't take us very far, quite honestly. So in order to make progress, I said we need to make assumptions. So here's a possible assumption, which is called ignorability. So we have two variables, A and B. And I'm interested in how B depends on A. And there are various things I can intervene on A to set its value, or I can just leave it idle. In other words, I can tell you the value of the intervention variable FA. And I'm making this assumption that it doesn't matter how A took on its value, whether I twiddled a knob or whether nature did the job of setting a value for A, that in order to predict B, I mean, which is to say the conditional distribution of B given A in whatever regime I'm mentioning, it's the same. It doesn't matter which regime I'm mentioning. In other words, it says if I look at the conditional distribution of B, B anyway, B if the distribution of B given the value of A and given the regime in which I tell you how A came to take the value it did take, it actually doesn't depend on that regime. What that means is that conditional distribution B given A is a modular component, the same in all regimes. And in particular, if I can observe that conditional distribution in observational data, then under this assumption, it would be identical to what I would see if I were to intervene on A. So that allows causal inference. What would happen to B if I intervened on A? And I say that in that case, we can say that A causes B. I put that in quotes because it might be that, in fact, the distribution of B given A doesn't even depend on A. It might not cause it at all. But the point is that we understand what we're talking about is the interventional effect of A on B as we can assess it from observational data. That's all very nice, and it's very great, and we can do lots of things with it. The only problem is it's generally an entirely implausible assumption in very many cases of interest. In most cases of interest, you won't be able to justify that that distribution of B given A is the same, no matter whether you just observe A naturally or whether you kick it. But you can make whatever assumptions you want, but you'd better try and justify them. You probably can't justify this empirically if you can't actually kick A. But you'd better have a jolly good reason for trying to persuade me that it's true. But let's get back to the formal semantics. So I've pointed out that we can express what's called the ignorability property as saying the property of B given the value of A and how it came about FA. It doesn't depend on how A came about FA. And in the language of conditional independence, I can write that B is independent of FA. Once you know A, the distribution of B doesn't depend on FA. Now, there's an interesting twist here that FA, I said, was not a random variable. And usually when you think of independence relationships, they relate random variables. In this particular case, there's no issue. It makes perfectly sense that B does not depend on FA once I know A. FA doesn't have to be random. It makes perfect sense. So I call this an extended conditional independence property. And there's a lot of formal theory which says that essentially you don't have to have random variables. You can represent and manipulate such extended conditional independence properties using the identical algebraic rules that you're familiar with already for regular conditional independence. Remember, I haven't talked about graphs at all yet. I'm representing now my causal assumptions by means of extended conditional independence. So this is the ignorability is a very simple one and the most implausible one. Often you will have conditional ignorability where this will hold when you've already conditioned on some other observed or unobserved variables. But these are the kind of assumptions that you want to make. So we now have a formal language for talking about causality without yet talking about graphs, but in terms of this very slight extension of very straightforward probabilistic conditional independence, simply by introducing these intervention indicators. And once you have expressed such independence properties and they're your assumptions, if you like, they're your inputs to the problem, and you can then manipulate, you can just use the algebraic properties of conditional independence to deduce the consequences. So you have input assumptions and you determine causal consequences. And that's what I would say is what we're doing by causal inference. Right, so I've got a language now, but I haven't yet related it to graphical representations. So let's do that. We do that by taking a DAG and adding extra variables to it. I mean, in other words, maybe adding is the wrong word, but we have DAGs which include intervention variables explicitly together with the more usual stochastic variables. And this supports causal interpretation, the kind of causal interpretation I've already described, which uses the independence of regime in order to say we can transform modular components across regimes. And how does it do so? It's exactly the same as in a probabilistic graph. We use deseparation, the same semantics that we had a probabilistic graph. The only difference is because we've now got explicit intervention indicators represented, we can represent things which represent causal properties. And one thing I want to make very, very clearly is we are representing causal properties in a graph, but not by use of the arrows. It is certainly not directly represented by the arrows. It's still the case that the arrows only allow a very indirect representation by means of the semantics of deseparation. So here is a rather simple augmented DAG. Because there's no arrow directly from FA to B, it represents the extended conditional independence property. B is independent of FA given A, which we've already seen. That is what we call ignorability. So that ignorability is very easily represented. That assumption is represented by a DAG which it contains, as well as A and B, the intervention operator FA. And I put non-stochastic variables in squares just to make it clear, but actually in terms of the semantics, we treat them essentially on a par with the stochastic variables. Right, let's go back to the question of Markov equivalence. If you remember, when we looked at the purely probabilistic DAG, without thinking about causality, there were those three different DAGs which all were completely Markov equivalent. They're just different parallel ways of representing the identical property that A is independent of B given C. I'm now going to modify those slightly by putting in an intervention operator which changes A, allows you to change A. And those are three different assumptions about how the world behaves. They may, in any case, they may or may not describe how the world behaves, but they are assumptions. And it turns out now that they're no longer all three equivalent. The top one it represents that B and C together are independent of FA given A. That is to say, how B and C depend on A doesn't depend on whether A arose naturally or by tweaking. And the other two, it turns out, are still Markov equivalent. They are two equivalent ways of saying the same thing. So the top one, if you like, said A causes B, C. This one says that B and C actually are marginally independent of FA, so it doesn't matter what I do to A, it won't have any effect on B and C. So that clearly means A doesn't cause B and C. And the important point here is that these two, there is still some Markov equivalence. If I put intervention variables in, I can still have different graphs which say the same thing. And in particular, you'll know that the arrow between B and C can go either way, and it doesn't say anything about a causal relationship between B and C. And that is because it only talks about intervening on A, and therefore it can't possibly say anything about a causal relationship between B and C. Let's go back to the instrumental variable problem. I've represented it in a slightly different way. I've turned it on its side, but there we are. There are two different ways you can think about instrumental variables. One represented on the left and the other represented on the right, where I've introduced an additional variable V, and X and Z are conditionally independent given V. Remember, these are purely probabilistic DAGs, no causal interpretation. Now, I'm only interested in the four variables X, Y, Z, and U. V is of no concern to me at all, but it's represented. But it turns out that if you think about what are the conditional independences between those four variables, ignoring V, they're identical. It doesn't matter whether you use the left-hand graph or the right-hand graph. If you want to represent the relationships below between those four fundamental variables, you can use either graph. They are the same. Let's now move to a causal interpretation. Same pictures. Now, we're still a bit vague about what a causal DAG is, but this one looks like that was the direct arrow from Z to X. We think that that's representing the fact that Z is a cause of X. And in this one, there's no such arrow. There's merely a common cause, V, between X and Z. And that will represent the case that Z is not a cause of X. And if you think that those two things are different, and they certainly sound different, then you will regard those two graphs as saying different things. And I've seen in the literature various if you think that it matters for instrumental variable that Z should have an effect on X, then you might be worried that this might not be regarded as appropriate for representing an instrumental variable where Z does not have an effect on X, but merely has a common cause with X. However, what we're interested in is the effect of intervening on X. So I'm going to add a variable fx and think about the assumptions embodied in these two graphs as they relate to the variables I care about, X, Y, Z, and U. V is there, but I don't care about it. And it turns out that in terms of the variables I care about, and anything I can do with those, these are identical. They represent the identical extended conditional independence and therefore the identical causal properties. Once we've got what I call an augmented graph, where we explicitly put in the intervention variables, we can see that certain things which seem to be important actually aren't important at all. I can work with either of these graphs. And in fact, the general theory, anything, well, pretty much anything that you do with instrumental variables can be done in either case, except for one thing. There's a whole area which actually recently won a Nobel Prize for economics, which is to do with principal stratum analysis. I'm not going to go into that. Some of you will know it. And this we're talking about how X, unless X depends directly on Z, you can't actually talk about the principal stratum analysis. So although you actually don't need to distinguish with these two graphs for anything sensible you do, if you're going to work in terms of principal stratum analysis, you're stuck with this one. And if that's the situation, you can't even get started. Right, now let's get back to augmented graphs and think about what Yuda Pearl does with his DAGs. What he does is he takes what looks like an ordinary probabilistic DAG and he thinks of each variable as being augmented by an associate intervention operator for every random node in the problem. And what that means is essentially every arrow now has a causal interpretation. And that is saying lots of things. It is relating lots of different regimes. It doesn't matter which variables I intervene on and which variables I leave to nature to decide on. It basically relates all those regimes together in ways I'll describe shortly. And the important point is, if that is a valid representation of how the actual world behaves, then it will allow a causal inference from observational data. But the when valid is a very important qualification. So here's a probabilistic DAG, and in purely probabilistic terms, it has some conditional independence properties. For example, it says that C and D are independent given A and B, but it doesn't say much about how C depends on A and B. Whereas a Pearlian DAG would look the same, but it would say something about C depending on A and B. It says that this, for example, implicitly, I can think of intervening on A and B. And it says the distribution of C given A and B will be the same no matter whether A and B were generated by nature or by me tweaking a knob or one or not the other or whatever. They're all the same condition of distribution. That is an understanding of a Pearlian DAG, and it's implicit. And I think that's great. It's very nice. It's very clear, but it's ambiguous in the sense that if I see that DAG, I don't know whether I should interpret it as a purely probabilistic DAG like that, or as a Pearlian DAG with that additional understanding. And I don't like the fact that that's ambiguous, and therefore I suggest that it could be clearly represented by what I call the augmented Pearlian DAG. All you got to do is throw in those intervention operators for every single variable. And what's nice about that is first of all, it doesn't look like a probabilistic DAG, so you're not going to confuse it. And what's even nicer is that it actually represents your assumptions by the semantics, because, for example, using deseparation, we can read off that as long as I'm not intervening on C, so if FC is idle, but the distribution of C conditional, the values for A and B doesn't matter, doesn't depend on FA and B, doesn't depend on how they were set. That's exactly what Pearl was saying. But instead of having to look at that graph and remembering in the background that that's what it means, I got it there explicitly, and it's represented, and you can just read off the consequences from the graph. So what does that mean? Suppose I've got a probabilistic DAG. What can I do with it? Maybe I just do what it looks like I've been doing here. I take a probabilistic DAG and I simply add intervention indicators to make it into a causal DAG. Can I do that? Well, I can do it, but why should I do it? And I remind you once again that the behavior of the system when I kick it may or may not bear some relationship with its behavior when I observe it. So to represent the system by such a Perlian or augmented DAG, that's my 45-minute reminder. Then I don't, I'm making strong assumptions. And for example, you have, if you do that, you have the following consequence, that if it turns out in the undisturbed world, two variables are, say, marginally independent, then in the disturbed worlds, neither can be a cause of the other. Now, this is something called probabilistic causality, which is often assumed. And it's a bit tempting, actually, but I think it's assumed a bit too readily. And there may be cases where it's appropriate, but it's not obviously appropriate. What I would say is that the best you could do is say that you can hypothesize properties like that, but you better jolly well investigate whether they're true by doing the interventions and checking. So causal discovery might give you some sort of hypothesis you can check by doing experiments, but I think it's rather dangerous to think you actually discovered something. So what do we take home from everything I've said? The same DAG can rather confusingly have numerous interpretations: clear probabilistic with clear semantics, causal with rather vague semantics, Perlian or augmented Perlian with clear semantics. But whatever you do with your DAG, you have to understand what it's saying about the real world and ideally justify it or test it. And very importantly, don't jump between interpretations without being clear that you are jumping into the unknown. And as for the recommended way of representing causality I've been describing to you, Perlian DAG or appropriate augmented DAG. The main difference is Perlian DAG allows intervention on everything, whereas an augmented DAG might only consider interventions on things you care about intervening on, but otherwise they're pretty much the same. They do have clear and explicit semantics, namely that the distribution of any intervenable variable conditional on its parents will be the same in observational interventional settings, and that is a very strong assumption that needs justification. So Pearl in particular has done some absolutely remarkable work on what you can read off a Perlian DAG, what consequences you can take on. But in my view, he takes far too little attention to the important question of whether the assumptions which I feed in before I can read off those consequences have any relationship to what's happening on the real world. So that's it from me. I'll just end by saying that I've appreciated, Carlo, all the good times we've had together, the good work we've done together, and I wish you a relaxing, peaceful, and extremely enjoyable retirement. Thank you very much indeed.
Any questions in the room?
There is a question in the chat. Yes, I'll read it out. Maybe too philosophical, but why is an observation of an intervention different to any other kind of observation?
Because we're not observing it. We're hypothesizing it. We're thinking about what would happen if I kick the system, for example. I don't have to kick, if I do kick the system, well, I suppose I observe that I've kicked the system. But most of the time, I'm thinking, I'm talking about things which haven't happened. The variable is there to discuss different possibilities. and to describe what I might expect to see and how they might be related under those different possibilities. So it's not exactly an observation.
Any other questions?
Thank you very much. Hui is going to introduce Carlo.
Good morning, everybody. I'm Hui Guo, and as a colleague, office mate, and very close friend of Carlo Berzuini, so it's a great honor for me to introduce you today. Professor Carlo Berzuini earned a professorship in biostatistics at the University of Manchester in 2011. Soon after officially starting his UK residential work after retiring from his professorial position in Italy. Some of his major contributions are in the joint modeling of longitudinal and time-to-event data. His first practical method paper was published in 1996. Bayesian solution to the unidentifiability problem in age period cohort modeling of time trends with David Clayton. Epidemiological forecasting prediction of protein-protein affinity through the novel concept of supra-domain in 2004 with Sarah Teichmann. As an inventor of the important class of sequential Monte Carlo methods of inference, also known as practical filters in 1997 with Wally Jukes. He won a scientific award from the Cambridge Isaac Newton Institute and secured a research grant from the UK Medical Research Council, which led him to successfully collaborate with Professor Phil Davies in causative interaction and the assessment of dynamic treatment regimes. He was lead editor of a landmark book in causal inference in 2012 and lead organizer of the first international conference in causal inference held in Europe. Actually, it was in University of Cambridge. Since 2011, he worked within his Manchester group on Bayesian extensions of Mendelian randomization methods in collaboration with me, and in the development of Bayesian methods of pain perception with Deborah Talmy. He has an extensive interdisciplinary record, most recently in application of causal inference to early COVID-19 data in collaboration with Professor Luisa Bullardinelli, who is actually with us today. So yeah, it's my great pleasure to welcome Professor Carlo Berzuini.
Hi, thanks for being here. My name is Carlo Berzuini, and this is my first day as an emeritus of the University of Manchester. And I decided to pay a visit to my country of origin, which is Italy. The title of my talk is A Causal AI for Healthcare. Causal, because causality is the main theme of my talk. The word AI is omnipresent, but I would sincerely advocate it to be banned from ordinary discourse. It's a fake. Artificial intelligence is not intelligent at all, at least not in the sense that we give to the primary quality of human intelligence, which is reasoning from causes to effects. Unfortunately, in its standard present form, AI does not incorporate causality. And in this workshop, we want to show you the implication of this deficiency. Well, I'm not against artificial intelligence. How could I be? Machine learning algorithms have a great future in healthcare. For example, robotics, a revolution in surgery, medical imaging, a revolution in early detection of disease, the ability to predict the folding of proteins, on the basis of their RNA sequence, a revolution in biology, in science, and in our ability to design new drugs. So how could I be against AI? Actually, the problem with AI is the following, that if you look at it from a cognitive point of view, AI is confined in a narrow territory. It does nothing more than classification, and therefore it is unable to perform tasks which are vital for the innovation of healthcare. In general, it's unable to predict the consequence of intervening in the world, of changing the world. And so in particular, it is unable to exploit the big data, the large quantity of data in the hospitals that are gradually made available to criticize the status quo, the way things are currently done, therapies, therapeutic regimes. Unable, for example, to realize that a certain treatment doesn't help, or it doesn't help particular groups or classes of patients. So, on reflections, this inability of improving the world works dangerously in favor of keeping the status quo. In this workshop, we give examples of how important causal reasoning is in healthcare innovation. In the 70s, who remembers that? Causal probabilistic networks were used in the development of expert systems for clinical diagnosis. Those early efforts were unsuccessful. In the next talk, Davide Luciani will explain the reasons for that failure and show us that it's possible today to incorporate causal knowledge in a new generation of expert systems that are able to deal with imperfect information about the patient, to produce explainable output, and to create a human-machine partnership which engages the critical mind of the doctor. Davide will leave the stage to Hiren Patel, a neurosurgeon who collects and analyzes hospital data to address questions about the efficacy of surgical interventions. With hospital data, we enter the realm of real-world data, also called observational data. They are found in regional health or epidemiological registries and general practitioner databases and genomic databases. You may call them big data if you like. The questions that Hiren tackles are causal questions of the kind, for example, will this intervention be beneficial for this particular patient? Part of the medical community thinks that the only way of tackling causal questions is via randomized clinical trials, RCTs. They do not know that causal reasoning helps us analyze real-world data in such a way to mimic an experiment, and that in this way we may avoid non-necessary trials, or improve experimental design, or replace experiments when they are unfeasible or unethical, and also to tackle a larger space of scientific questions that's possible within the constraints of an experiment. But this kind of data are difficult to analyze. And this is because in the absence of randomizations, there are several sources of bias that can invalidate the conclusions of the study. Causal inference methods offer ways of dealing with these difficulties. Let me illustrate this through the example depicted in this slide. Suppose we have hospital data from a sample of patients where each patient is characterized by 3 variables, which you see in the graph. And these variables are B for baseline, which describes the condition of the patient at baseline. Then we have variable T standing for treatment, that indicates whether the patient has or has not undergone a treatment of interest. The third variable, Y, records the clinical outcome for the patient. Suppose our aim is to use the data to assess the beneficial effect of the treatment and whether this effect varies across patient strata. Call it personalized medicine if you want. By describing the problem as we have done here through a causal graph, we are on our way for a causal understanding of the problem, and this will enable us detect inferential difficulties we would otherwise overlook. We have included in the graph a node U representing baseline information about the patient which has not been recorded and therefore not included in the analysis. The arrow from U to T in the graph indicates that the doctors may have taken into account the unrecorded information in their decision to intervene on the patient. At the same time, the graph makes allowance for the possibility that the unrecorded information has influenced the clinical outcomes. And a consequence of all this is that variable U acts as an unknown confounder of the relationship between T and Y. In the spirit of machine learning, we may aim at a purely predictive model, for example, developing a model that predicts the clinical outcome Y on the basis of variables T and B. That would be dangerous because the model would be valid only if applied in a population where the distribution of U and the treatment decision criteria are the same as those in the population which generated the data. Even worse, such an analysis would have little meaning from a causal point of view, and we would not be able to attach to the estimated parameters of such a model any causal meaning. If we instead frame the problem as a problem of causation, we may avail ourselves of such methods as propensity scoring for attenuating the confounding bias. The bottom line here is that causal inference methods help us exploit hospital data as they are gradually made available to increase our insight into the efficacy of the treatments that are part of the medical routine. Of foremost importance in this kind of analysis is the possibility of detecting interactions between the baseline data and the clinical intervention, pointing to particular strata of the patient population where the treatment is unhelpful. Let's now move to the next important topic that I think plays a role in healthcare research innovation. As data accumulate in epidemiological registries, we may wish to monitor rates of exposure of the population to certain lifestyle or environmental factors and to measure the effects of the exposure on specific medical outcome. In this particular example in the slide, attention focuses on obesity and the effect of obesity on heart disease. A simple analysis of the association between obesity and heart disease does not tell us anything about the causal effect of obesity on heart disease due to presence of unknown confounders between these two variables. Again, it is by translating the problem into a causal graph shown in the slide that we can justify an approach to the problem that uses genetic variation as an instrumental variable to get a causally meaningful estimate of the effect of interest. This approach will be discussed today by Hui Guo. She will moreover argue in favor of a Bayesian approach to the problem that allows us to test for presence of the causal effect by using an interval null rather than a point null hypothesis, which carries important advantages, as she will discuss. Again, the bottom line here is somewhat tautological, is that causal reasoning is at the basis of methods to get meaningful answers to causal questions from hospital or epidemiological data. In the rest of my talk, I will dwell on the problem of using real-world data to provide mechanistic explanations of disease. I shall now discuss the cognitive steps that lead to a solution of the problem, that involve a mixture of creative imagination and causal reasoning, exactly what AI misses. Before getting into details, please have a look at this slide, which conveys the general idea. We have evidence that poverty increases the risk of cardiovascular disease. A number of epidemiological studies prove this assertion. But we want to probe deeper. We want to test hypotheses about possible mechanisms that explain that link. One such hypothesis, described at the bottom of the slide, is that the effect of poverty on heart disease is mediated by a chain of biological events occurring in the order in the amygdala, in the bone marrow, and in the arteries. I will now discuss the problem at a deeper level of detail. The application example I have chosen is inspired by a study on the cardiovascular effects of poverty cited in the slide. The study is based on data in the form of positron emission tomography scan images, and AI plays an important role in translating these images into manipulable data. I will revisit the study from the point of view of causal inference, also in the attempt to illustrate the theory presented this morning by Professor Dawid. Let me introduce you to the problem by first saying something about PET imaging. Today we have the ability of obtaining PET images of different organs in a patient, and from them organ-specific measures of patient's health. Just two examples are illustrated in this slide. They are taken from the paper cited here at the bottom. On the left part of the slide, you see images from the amygdala. Amygdala is a part of the brain involved in the response to psychological stress and in the generation of feelings of anxiety. Here in this figure, a normal amygdala at the top is compared with an overactive amygdala, a sign of anxiety. Now move to the right part of the slide, and here you see PET images from the aorta. On top, you see a normal aorta. At the bottom, a severely inflamed aorta, which predicts cardiovascular risk. These examples show that PET imaging probes what is going on in different parts of the patient's organism, and this will allow early detection of disease, enhanced diagnosis, enhanced prognosis, and personalized medicine. And as we are now going to show, our insight into disease mechanisms. I shall now describe a study, not mine, which uses PET data to provide a mechanistic explanation of the observed association between poverty and heart disease. My intention here is not to present a novel scientific discovery. As a matter of fact, I was not involved in the study I am going to describe. My intention here is to show that if you want to learn from data, you have to use a mixture of creativity, imagination, and causal reasoning. which is much different from just taking a good algorithm off the shelf. Imagine that all this is the result of a collaborative effort where statisticians interact with medical experts together. A group of researchers, perhaps sitting around a table with cups of coffee scattered on it. These researchers start with delineating the phenomenon to be explained, and they imagine a mechanism that explains the phenomenon. They must characterize the components of the mechanism and the putative causal relationships between these components. In doing this, the scientists will take into account evidential constraints, such as those generated by experiments conducted on parts of the mechanism, and what we may generically call medical knowledge, as found in the literature. For example, the pieces of knowledge you read here, one piece being that stress response to a low socioeconomic status begins in the brain salience network, specifically in the amygdala, and that activation of this network increases sympathetic output, which in turn triggers increased bone marrow hematopoietic stem cell proliferation, thereby accelerating leukopoiesis, which in turn causes aortic inflammation, a major driver of cardiovascular disease. The scientists will also take into account the temporal ordering, such as in this graph, the fact that arterial inflammation precedes in time the cardiovascular events. Well, we represent all this motley in the form of a graph, a map of our knowledge, causal knowledge. The various components are put together into a mechanistic hypothesis, in this case, one that explains the adverse effect of poverty on cardiovascular health as involving a chain of events in the amygdala, in the bone marrow, and the arteries. Typically, the arrows of the graph will represent causal relationships in conformity with the causal graph semantics that Professor Dawid has introduced in the preceding talk. You see here an example of a consensus graph. Note that it represents not just one, but a collection of possible mechanisms. And this is because there is a multitude of possible causal paths from poverty to disease in the graph. We may regard each of these paths as one possible mechanism. There may be several mechanisms operating at the same time. Some of them are included simply because no evidence allows the researchers to discredit them, to ignore them. Some causal relationships between parts of the mechanisms are a priori excluded. Note, for example, in this graph that the possible direct effect of poverty on variable B is excluded. Biological considerations must be at play here. In summary, the scientists here are imagining mechanisms that connect poverty to cardiovascular disease and representing them by a graph. The remaining part of the enterprise will involve using the data together with the graph to generate evidence that supports one or more mechanisms depicted in the graph, assuming, of course, that the graph depicts all possible ways in which the world may work, an assumption that we, unfortunately, shall never be able to prove empirically. But I'm running too fast here. I will discuss this later. The causal graph will typically not be a post hoc representation of the results of a collective imagination effort. On the contrary, the scientists will meet and exercise their mechanistic imagination while drawing the causal graph. in successive iterations corresponding to gradually updated versions of the graph. The graph guides the cognitive steps leading to the final model through successive versions of the model. And each of these versions of the graph of the model may be made public to the medical community to stimulate feedback. Even more important is the ability of the causal graph to facilitate interaction between medical and statistical experts. It's a common language for talking to each other, something more than choosing a machine learning algorithm. What is apparently here is the enormous space that this activity reserves to imagination, compared, I think, to typical practice in standard AI. But let us go back to the graph shown in the slide. One thing we see here is that some components of the mechanism, as represented by nodes in the graph, are anchored to well-defined physiological compartments that occupy a defined space in the body, in the human body. This is, for example, the case of node B that represents the activity of the bone marrow, but not the case for poverty, of course. Another thing we note is that the graph is directed and acyclic. Directed in the sense that the edges connecting nodes have direction. They are arrows. And acyclic in the sense that you cannot start from one node in the graph and get back to the same node by following the directions of the arrow. It's a DAG. There is one question which, however, I shall postpone in my talk, and is the extent to which this class of graphs is able to capture the way the components interact with each other. The ability of DAGs to capture the way the world works. For example, this graph excludes the possibility that B exerts a causal influence on A. For the time being, let us keep the question under the rug. What we have discussed so far is the qualitative part of the model. We have to add quantitative specifications, which means distributional specifications and functional relationships in order to turn this into a full probability model where each node of the graph, each variable, is associated with a stochastic variable in the model defined on a suitable domain. The model in our particular example will typically belong to the class of recursive structural equations. But you would be in error if you think that we can rush to estimate the parameters of the model on the basis of the data without further thinking. We first need to check whether the assumptions embodied in the graph and the data we have allow the unknown parameters in the model to be meaningfully estimated and interpreted in a causal way. In other words, we need to check identification before doing estimation. In order to do this, we first need to impose a causal semantics on the graph. And we now do this in the way that Professor Dawid has described in his talk. We follow him by imposing on the graph a causal semantics through the use of intervention indicators. Here you see that we have augmented the graph by adding intervention indicators. See them in red color. The represented interventions are thought of as at least potentially occurring in the real world. For example, the intervention represented by indicator FA might indicate a possibly hypothetical regime where interventions are made on the individual's amygdala via antidepressants. The way the indicators are placed in the graph is important. For example, the way we have placed the indicator FA represents our assumptions that the corresponding intervention would not affect any variable in the graph, except through affecting the amygdala. The extended conditional independence theory you heard from Professor Dawid justifies the application of standard deseparation or moralization graphical criteria to read off the graph conditional independence relationships that involve intervention indicators and therefore can be understood as causal assumptions. Consider, for example, the third relationship in this list. It asserts that variable I is independent of the indicator FB given A and B. How do we interpret this? In the sense that once we know the values of variables A and B, and we ask about the value of variable I, we no longer need to ask whether the recorded value of B arose observationally or interventionally. Yeah, and because both A and B are observed in our study, this relationship defines the necessary ignorability condition for the effect of B on I to be meaningfully estimated on the basis of our data. Other relationships listed here follow from the graph. And it turns out that they provide the necessary ignorability conditions for all the causal influences represented in the graph to be quantifiable on the basis of our data. Well, forgive me for getting into complex notation, but the main idea is simple. We have a graphical tool to represent our causal assumptions about the problem and at the same time to determine whether on the basis of those assumptions and of the data we can get meaningful estimates of the causal effects of interest so that in the basis of these we can answer the scientific question of interest. Having been reassured that in our model all the causal effects of interest can be meaningfully estimated, we proceed with the study. PET images of the involved quantities will be collected from a sample of patients. Then AI algorithms will be used to transform the images into organ-specific quantitative measures of health, anxiety, leukopoiesis, arterial inflammation. And then each study participant will be followed up for a certain period, for example, 5 years, for occurrence of major adverse cardiovascular events. The model will then be completed with the necessary quantitative specifications and the causal effects estimated on the basis of the data. The results you see in this slide have been taken from the already cited paper. They have been obtained by using the same graph and the same implicit causal assumptions that I have described previously. And if you look into the numbers and the statistical significance, you see that these results corroborate the hypothesis, the theory that there is a causal pathway from poverty to cardiovascular disease where one of the mechanisms involves events in the amygdala the consequent stimulation of leukopoiesis and the consequent inflammation of the arteries. I am not going to discuss these results in detail from a substantive point of view. I would like to reflect on our approach so far. We have given a great deal of thought and imagination to the problem. We have not rushed to pick up an algorithm from a shelf and applied it to the data. We have used the best of our brains, in particular by evaluating assumptions in the light of the existing knowledge. But now comes the part of my talk where I shall cool your enthusiasms a bit. No matter how carefully we have done the exercise, we will never be sure that the conclusions of our analysis are free of bias. Why so? Because how can we know whether our model represents the way the world works? Well, we have some knowledge of the underlying mechanisms, but not a godlike knowledge, and therefore we cannot exclude that the assumptions embodied in our graph are wrong. And it may well be that we have no power to realize this. Let me give you an example of this, and let us first go back to our model. One of the assumptions embodied in our model, the one you see now on the slide, is that variables A, B, and I are not affected by unknown confounding. Suppose this assumption is wrong, which is difficult to check. And moreover, suppose that we have overlooked the role of bone marrow in the mechanism and consequently excluded this variable from analysis, assuming instead that variable A sends an arrow directly into variable I. So we unknowingly find ourselves in the situation of using a model which is wrong, in the sense that it's different from the model you see now on the slide, which better describes the world, and we may conveniently call it the true model. Under our model, the causal chain of interest is identifiable. But under the true model, the one you see in the slide, it is not. And we will not be aware of this, so that in the end, we will find ourselves defending a wrong theory. Until in the future, someone with more data, better knowledge, and better technology will falsify our model and our conclusions. Suppose, for example, that someone in the future performs a literature search by using an AI tool, for example, and this guy discovers that there exists an exogenous factor that is simultaneously a causal precursor of amygdalar activity and aorta inflammation. This will immediately invalidate our model, our theory, and our conclusions, and prompt a revision of our model and our theory in what can be described as a never-ending research process. The next and last example I'm going to give you is even scarier. Our first model acknowledged the possible causal influence of A on B, but excluded a possible effect in the reverse direction of B on A. If a future experiment were to demonstrate that this is not the case, in other words, that A and B are linked by bidirectional causal relationship, we would be in trouble. We would need a more general class of models than DAGs. Different choices would be available, corresponding to different assumptions about an unobservable underlying data generating process. As a consequence, different conditional independence interpretations of the graph you see on the slide would be possible. We have got, in a difficult area, still a subject of research and outside the scope of my talk. This was, in fact, the last slide in my talk, and I hope I have conveyed the main idea that if we want to innovate in healthcare, and my talk has focused in particular on healthcare research, we need machine learning and causal reasoning.
I can start off, and a very interesting talk, Carlo. Every time I speak with you, I learn a lot. So just
Thank you.
looking forward.
Also when I speak with you.
So yeah, let's looking forward. How you see AI interacts with causal inference in medical research?
Yeah. Well, I made this example, and the example is one example of how the two paradigms can interact. Wait, I think you can answer better than I do to this question. Anyway, there is also the possibility.
We need
That,
your wisdom on this.
yeah, there is no, because you are actually looking at this. So there is also the possibility of you have a study, you know, based on causal inference, and certain calculate. For example, in instrumental variables, you know, you have these two stages of the model, and you have the stage where you model the exposure, as it depends on this enormous number of SNPs of instrumental variables, and then you have. In this first model, you could use AI, random forests, you know, to create a better model of the relationship between the instrumental variables, the SNPs and the exposure. So random forest machine learning can be plugged into this causal inference framework.
Thank you very much, Carlo. So for a very educational session this morning, and now we're off for lunch. So we'll be coming back at 2 o'clock. Thank you.
Good afternoon. I'm here to introduce a probabilistic expert system to support physicians in the diagnosis of patients admitted in emergency departments. The system that is based on a Bayesian model, in its first version, was focused on the diagnosis of pulmonary embolism. That is why it has been called BiPAD, from Bias Assisted Pulmonary Embolism Diagnosis. It now covers most of the diagnosis related to diseases of cardiopulmonary origin. That is about 40% of patients admitted in emergency departments. This work is part of a project that I've coordinated for more than 20 years, working with many physicians and also experts in advanced statistical and computational methods. Okay, in my talk, I will first consider probabilistic expert systems from a medical perspective. Then I will go through the key methodological steps involved in our model development. As a Bayesian network, the model has to have both its qualitative and quantitative part to be specified, that is the graphical structure, and the quantitative parameters indicating the strength involved in the association portrayed by the graphical leaves. where the graphical structure was defined on the grounds of well-consolidated causal knowledge, the parameters were estimated from data. So in practice, we apply a hybrid approach to model development, since we took our graphical structure for granted while estimating the parameters from data. Actually, we did not really take our graphical structure for granted, because it was subjected to a long process of revision that we call a structure refinement. That revision was fueled by the same data we collected to train our data, to train our parameters. These data were derived from hospital records, came from one hospital, of patients admitted in emergency departments because they complain of a specific series of symptoms. We will then see the diagnostic performance we achieve on a new sample of data, and we will then consider related work that these Bayesian networks also developed for diagnostic purpose in the last 10 years. But let me start with an anecdotal story. It is about a patient I really saw many years ago when I was a medical student in the emergency department. That patient was around 40 years of age. He was brought by an ambulance found in a state of confusion. So he was unable to tell what had happened to him, nor there was anybody that could do so. He was visited by 3 doctors on charge in 3 different surgeries, but none of them could provide a satisfactory diagnostic explanation. So they asked for the opinion of a 4th doctor that at that time was my supervisor. After a first glance, he asked to him, "Could you please show me your tongue?" The patient carried out the request, and then it was noted a bite mark on the left edge of his tongue. Then, at least to physicians, it became clear that the patient had suffered an epileptic seizure, and it was confused because still in a post-critical phase. That question that was so enlightening in part depended by the presumably negative test the patient got during his previous visit, including blood count, chest X-rays, electrocardiogram. But nonetheless, I believe that this story is interesting for at least 2 reasons. The first is that it shows that the problem here arises from the big number of diagnostic hypotheses the doctor needs to consider when the patient presents with few and generic manifestations. This also applies to patients with pulmonary embolism. In most cases, they present themselves with difficulty in breathing, palpitations, chest pain. They may pass out for a few seconds. All symptoms that are do also occur in far more common diseases such as myocardial infarction, an asthmatic attack, a vasovagal crisis, or in more dangerous disorders such as aortic dissection. With this patient, to make a diagnosis is like to find a needle in a haystack, like the title of our work remarks. It was exactly because of that we ended up to include in our Bayesian network more than 350 variables. 235 of those were observable. The second reason why I told this story is that it shows the effort of imagination that sometimes is required by the diagnostic reasoning. The diagnostic reasoning sometimes is fueled by a small detail that not necessarily involve a complex and sophisticated and advanced diagnostic machinery, but it demands to be thought by the doctor. We would all hope that such an imagination would be rooted on the best scientific knowledge, but when in front of a patient, it's not that easy to retrieve the scientific knowledge that is relevant for the case on hand. The reason why so is that scientific knowledge is mainly structured in causal terms. as it typically derives from experiments where you manipulate a condition at will to see whether the expected effects really occur. But the diagnosis proceeds in the reverse fashion. It starts from the partial complaints to look for the diagnostic explanation. That is, it goes from the effects to the causes. Physicians normally ask statisticians to the aid to compute indicators of such as the p-value, the confidence intervals, something that tell us something about the replicability of a scientific finding. They trust less in statisticians when it comes to time to provide their art, their clinical reasoning with a formal mathematical representation. But the good news is that when you develop a Bayesian network, it's not that difficult to assemble into it even scattered chunks of scientific knowledge. And then after you have presented your domain of interest, you might always rely on the application of the Bayes theorem to perform reverse conditioning, that is to compute the probability of the diagnosis given what you observed on your patient. Maybe it's worth to note that the goal here is not to discover new cause-effect relationships. Our goal was to represent the best state of, at best, the state of the art of well-consolidated causal knowledge. That is the way how doctors explain the functioning of the human body. After all, the clinician is demanded to select the best decision on the grounds of existing knowledge, no more than that. So, like many others in the past, we involved a panel of causal experts to elicit the causal graph to specify the qualitative part of our model. In so doing, we were helped by a tool that could take advantage of a general medical category. A medical variable could be classified, because according to this category, you can expect a causal role of the medical variable. Here are the medical variables, how the medical variables can be classified into general medical categories concerning those we included in our Bayesian network. You find the diseases, their manifestation, no matter which diagnostic procedure is employed to ascertain them. Then you have the risk factors. You have pathogenetic anomalies and comorbidities. So the interview was performed by starting from the medical complaints of the patients to look for the disease that could explain these manifestations. Then the network was progressively enriched by looking for risk factors explaining the occurrence of the diseases. And then we could have enriched the causal paths between the diseases and the manifestation by contemplating syndromes, organ failures, that is events of pathophysiological interest. Then the pathogenetic anomalies could also enrich the path between the risk factors and the diseases. And then comorbidities were considered because they could interact with any of the variable elicited so far. By following this procedure that allow us to cover the causal elicitation task quite systematically, you might note that only the roots and the leaf nodes indicate observable variables. All the other indicates latent variables. They are latent because they are not accessible within the hospital setting, but only in the experimental setting, on which the medical knowledge is rooted on. Having said this, having fulfilled the specification of our causal structure, we needed to specify also the quantitative part, so the parameters. We refrain from applying knowledge acquisition methods to elicit the quantitative parameters, like many have done at the end of the 80s or at the beginning of the 90s. At that time, Bayesian network maybe represented the turning point of artificial intelligence research, because they showed to be capable of simulating even the reasoning of advanced experts in a specific field. But at the beginning of the 90s, physicians started to become more interested in the empirical foundation of the reasoning. That is the evidence that was behind their decisions and medical judgments. Like the evidence-based medicine movement was dictating from around the same years. So because of that, and also to alleviate our physician from the burden of eliciting the too many parameters that were demanded by our Bayesian networks, we choose to estimate these parameters from data derived from a sample of hospital records. But to fill our conditional probability tables, that is where the quantitative part of the Bayesian network is stored, we needed to estimate 350,000 parameters. So like many have done to tackle the issue, we use conditional models, thanks to which a conditional probability table can be generated with a number of parameters that grows linearly with the number of the parent nodes, that is the covariance of the conditional models. The conditional models are the popular noisy or noisy max canonical models that are used to deal with binary variable or categorical variable based on an ordinal scale. But we also apply other canonical model to deal with categorical variable that were not based on an ordinal scale, but they were purely qualitative. As the continuous response variables are concerned, we use beta regression models. So the original quantitative scale was mapped into a bounded range of values. I cannot enter into many technical details here, but what is important is that in the end, we had only, let me say, 1,417 parameters to estimate. After we specified, we elicited for each of these parameters also the prior probability density, we had all we needed to implement the Bayesian learning of our parameters, given all the structural assumptions involved in our model. That is the graph and the conditional models. Of course, the role of the graph, the direct acyclic graph, is that of decomposing the likelihood of the data into several conditionally independent factors. We believe to have an advantage in comparison with machine learning approaches, in that with this structural assumption, we could to some extent mitigate the impact of our noisy data. Why they were noisy? Because hospital data are affected by a high proportion of missing values. As you know, when the patient is hospitalized, is only observed for what concerns the medical variable of interest. So the missingness here is informative, and so cannot but lead to estimate spurious associations and can lead to biased estimates. On the other hand, we were also concerned with the fact that with so many structural constraints, we might have forced too much our estimate toward prior features that no data could have reversed. So we acknowledge the need to perform a structural refinement of our structural constraints that was fueled by the same data. Here you see also the formalism that is involved in the bugs language, how the full Bayesian graphical model was specified. You see the parameters around the plate that represent the target of our estimates. So with Markov-Chain Monte Carlo techniques, we could get the posterior parameter densities. And from this posterior parameter density, we could get the expectations in order to generate, on the grounds of our collected data, our conditional probability tables. You can also note that only the list here in this small portion indicates observable variables. The latent structure had its empirical foundation as long as it could reproduce the empirical correlation among our observable variables. But was it really the case? To answer this question, we performed the structural refinement, and that was based on two kinds of analysis. The first focused on the parameters. That is, by looking at whether the prior parameter densities overlapped with the posterior parameter density, we derive an indicator to highlight those parameters that were completely insensitive to data. And in such a case, we attempt to simplify our latent structure. Here you see the plots about that allow us to compare the prior with the posterior densities, and at the end we end up with 1/3 of these parameters that prove to be not sensitive to data. Anyway, we were successful in preventing that any conditional probability table was based on a set of parameters that were entirely insensitive to data. In so doing, we increased the chance to detect structural problem on the grounds of prediction that turned out to be miscalibrated once the impact of all our observable variables was propagated through our latent structure. And this was the target of the second analysis that was based on calibration belts. Calibration belts are like a calibration curve. Perfectly calibrated prediction would meet the correspondent observation in the diagonal line. So anytime you see a point that is far from the diagonal line, that means that some miscalibration might be involved. But unlike calibration curve, calibration belts also inform us about the uncertainty involved in the miscalibration. This is possible thanks to the, thanks to the recalibration regression approach first introduced by Cox in the 50s. What is important for me is to highlight that the calibration belts prove to be very sensitive tools to detect structural problem. Here I show you an example that concern two diseases, myocardial infarction and its underlying causes, that is a coronary occlusion. Here you see that the prediction were miscalibrated, but also the manifestations of these two diseases were miscalibrated. These the D-dimer test levels and troponin levels. All these problems were fixed once we change our structure. Before you might have a D-dimer test positive, so D-dimer levels increase only when a myocardial infarction occurred. Then we understand that the D-dimer test could be positive also with a temporary coronary occlusion. The right to do so came from a paper. Once the literature was checked once more, we realized that you might have a positive D-dimer test signaling an intravascular coagulation within the coronary artery, even without that coagulation has the time to lead to the infarction of the myocardial tissue. So this example shows also that we refrain from apply a structural change only because we saw the calibration belts signaling some problems. We always need the literature support any change applied in our graph. This restriction was applied to maintain our graphical links with a proper causal interpretation. After the structural refinement was fulfilled, we checked at the diagnostic performance and also to the calibration belts of our model with a new sample of data. By new sample of data, I mean data derived from patients admitted in emergency departments and then hospitalized in 6 Italian hospitals, apart from the one of Bergamo, which provided us with a training sample. Also in the testing sample, we could rely on the definitive diagnostic confirmation that was obtained during the hospitalization process. Here you see our calibration belts. They concern 6 diseases because we focused on all diseases on which we had at least 10 positive diagnostic confirmation. I show you them. They are quite satisfactory. Actually, there is also the pulmonary embolism. You might note that the acute heart failure and its related complicating syndrome, that is pulmonary edema, show a limited, although significant, miscalibration. We refrain from applying further structural changes because we did not find support in the medical literature to do so. We also thought that the issue arises from a group of elderly patients that already suffered of a chronic heart disease and were admitted in the hospital maybe to prevent the worsening of their condition, even if they did not even complain of difficulty in breathing. That is symptoms known to occur in all patients with an acute heart failure. Maybe the hospitalization had to be somehow justified, and that might explain the overdoing of the diagnosis of acute heart failure. After all, when you use more source of information, it's in this case consolidated medical knowledge and clinical data, it's not always easy to decide which is the one to follow. As the diagnostic performance indicators are still concerned, we also compute the discrimination index to see the ability of our prediction in distinguishing among alternative diagnostic categories. Since we wanted to see more than 2 diagnostic categories like the classical concordance index does, we compute the M index to see the discrimination involved in 20 alternative diagnostic categories. The M index is interpreted like the concordance index. So you have 100% signaling a perfect discrimination, 50% means no discrimination, like flipping a coin. And what we had by considering only the observation that can be collected in the clinical visit is 83%, while employing all the observation in our testing sample, we obtain 91%. Now, you know that the discrimination index cannot but grow the more observation you consider. But our model was not designed to force doctor to enter all the observation that the Bayesian model contemplated. So it was conceived to be used flexibly, even to indicate the diagnostic procedure that could reduce the diagnostic uncertainty that was expected to reduce the diagnostic uncertainty. Because of that, we thought that was a good idea to compute the M index in these two distinct scenarios. As related work is concerned, here you see a table where we summarize the results of our review about all the Bayesian networks developed for diagnostic purposes in the last 10 years. In the first section, you see Bayesian networks developed only through knowledge acquisition methods. In the second section, you see Bayesian network developed through machine learning algorithms. That is, both the quantitative and the qualitative part was estimated from data. The last section is about Bayesian networks that also follow a hybrid approach to model development, like in our case. There are many model features addressed here. One of that allows you to see that only a minority of these models were tested on a real new sample of data. The other also shows that a few models focus on more than one diagnosis. But maybe what strikes more is the number of variables contemplated in the model domain. If you look at the second section, you see that the number of variables never exceeds a given threshold. So models developed through machine learning algorithms are never so big. Maybe the difficulty here arises from the difficulty to collect medical data of good quality when this data covers many variables. And particularly when structural learning is involved, the risk to face with spurious association rather than association that makes sense from a causal point of view cannot but increase. On the other side, you see that Bayesian networks developed through knowledge acquisition methods are not limited in their size. On the other hand, they have been often blamed to lack of empirical precision. The reason why I stressed so much the importance of a large model domain is not because I want to show that we built the largest Bayesian network ever built for diagnostic purposes. The size of the model domain is an essential feature to address a difficult clinical problem, that of the diagnosis of patients with few and generic symptoms. There are already scoring systems to aid the physician in the diagnosis of pulmonary embolism, and they are based on no more than 20 variables. However, to be applied on patients, the doctor need first to anticipate the possibility of a pulmonary embolism to occur. Unfortunately, several post-mortem studies show that in most patients died of pulmonary embolism, the physician did not even contemplate the possibility and the hypothesis of pulmonary embolism. It was exactly because of that to give a reason to physicians to use our expert system even without suspecting pulmonary embolism, even without suspecting a specific disease, that we ended up to extend the model domain with basically almost all the manifestations covered in the differential diagnosis of patients with symptoms like those occurring in pulmonary embolism. So this way, the doctors can start from what they objectively see in their patients, rather than starting from their own diagnostic conjectures. But coming back to our table, we can see that also the Bayesian networks developed through a hybrid approach are not that big too. Well, the hybrid approach deserves to be appreciated for several reasons. Concerning both the accessibility and the usefulness of the two sources of information employed in the hybrid approach. In the medical field, you can always rely on well-consolidated medical knowledge and causal knowledge. And this is helpful to save from structural learning that is very demanding in terms of data. It is helpful to estimate the parameters even from a data source as noisy as the hospital data are. It is important to remember that hospital data are the easiest source of medical data that can be accessed, and they potentially cover the full medical domain. It is rewarding, I believe, when you attempt to attest to what extent your diagnostic performance is robust by looking at on a new sample of data. And is useful to allow physicians to interpret the diagnostic predictions according to their own medical background that is framed on causal concepts. Having said that, when you employ two sources of information, the causal knowledge and the empirical data, the risk that these two sources conflict to each other arises the more features are modeled. In our case, what we did was mainly to acknowledge the need to address the structural refinement of our network. But why the structure was not perfect since the beginning, when it was elicited by our medical expert? With respect to that, I can say that it is impossible to explicitly exclude a link between two variables when you consider hundreds of medical variables, like in our case. As the medical literature is concerned, we saw many times that papers vary greatly in reporting the details of a causal path, even when they are dealing on the same causal path. Our practical target was to obtain a non-redundant representation of our domain, but the more subdomains were added, we had to revise the details of our causal paths. So all these things call for a structural revision. But maybe there is also an additional thing that is even more important than all these. That is, when you use a hybrid approach, is of utmost importance that your graphical structure do not only represent the cause-effect relationship that are known to exist. What matters more is how faithful is your graphical structure to the process your data are generated. With our data, we were well aware that they were selected on patients according to specific characteristics. That is, difficulty in breathing, palpitation, chest pain, fainting. Only after we extended our model to represent also this selection process, our calibration belt became useful to detect small problem to be fixed. So before that, these miscalibration were not really helpful in detecting local problems that had to be fixed. So we could say that such an extension of the model was rewarding, but it could also be safely omitted while testing our model on the testing data. After this, we might ask whether after all these developmental and validation efforts, we are at the end of our efforts, so whether we definitely achieved our goals, or we are rather at the beginning of an even more challenging path, since in theory, the application of this expert system in the clinical practice should begin now. Should physicians trust in the diagnostic prediction yielded by this model? We are certainly satisfied of the diagnostic performance attested on a new sample of data. It is true, 1/3 of the parameters proved to be insensitive to our sample, but nonetheless, the diagnostic predictions of interest proved to be testable. However, the cases that are more represented on average are the ones that weigh the most on statistical indicator of performance, whereas are the rarest cases that really represent a challenge for physicians. So because of that, we are currently testing our model on cases that, clinical cases that are reported by the New England Journal of Medicine to train physicians on real diagnostic challenges. We are always pleased to see when our model cope with these difficult cases. However, we also realize that some cases completely escape its domain. So should we conclude that our model is not yet ready for the clinical practice? Personally, I believe not. Even if physicians should not follow the prediction blindly, like the model was an oracle. It is exactly because the Bayesian network and the medical users share the same causal background that the doctors might find themselves in a position to criticize, to improve, to extend the model, even to cover those rare cases I talked about. You can always collect a new sample of data to estimate the quantitative part of this model extension. After all, is the intelligence of these systems, that is their ability to cover an astronomical number of clinical scenarios that make them always exposed to criticism. What I think is that this tool can be an essential ingredient to implement a cycle for the continuous improvement of the clinical practice. Exactly because they can address the clinical variability of this difficult diagnostic problem. In due time, this model will see not only its statistical performance improved, but it might work as a tool to implement personalized medicine. After all, the very development of this system proved to be a systematic way to check the consistency between well-consolidated medical knowledge derived experimentally and observation gathered from the clinical practice. That is the two main sources of information that doctors employ in their clinical practice. Thank you very much for your attention.
Thank you for interesting talk. That was very interesting. Does anybody have any questions?
If you find a conflict between your data and the structure of the part of the network, despite your refinement, the first things I think of is maybe the causal knowledge represented in that part, which appears to be in conflict, motivates an experimental study for clarifying the reasons why there is a conflict between the data and what is represented. So in this case, one of the benefits of the enterprise would be to motivate further investigations in certain parts of the knowledge. But then I think there may be selection effects, because your system suggests what sequences of tests have to be done in certain patients. I don't know how to express, but some bells ring in my mind. Maybe there are selection biases linked to the fact that certain variables are only tested in the patients if the system tells you to measure them. Sorry, I'm myself confused about the question. I don't know whether it makes sense.
I always believe that it makes a great sense also to use this theoretical tool where all the information that the doctor employs in his clinical mind are also checked whether they work or not, and if they do not work, why not to perform a clinical study, an experiment to solve the issues. As it concerns the bias, I always been used to deal with them by looking at them as potential bias. And so what matters for me is to have some tool in order to assess quantitatively the miscalibration that arises from these bias. Only when these bias are detected, I think you have a proper stimulus to go further, to improve. So there may be reason why through selection that is not like the selection process we model, because we could model that selection process because we were aware of the way we selected the patients. But of course, there are many other selection processes involved that cannot be modeled, unlike, for instance, you realize the reasons why a patient admitted in the emergency department is then hospitalized. What we can do, we need the study to understand the relationship between hospitalization and emergency department admission. For sure, it does not concern only about the medical conditions, but also departmental policies.
Carlo, I think that doctors are perhaps not quite as clever as you assume them to be, and perhaps they don't need all of this information presented to them in probabilities or not at one time. The thing with doctors is that they can also, in most conditions, watch their patients evolve. And actually the information that they need changes according to how their patient is.
Okay, thank you again.
Good afternoon, Matt, Sarah, thank you for organizing the day. I'm Hiren Patel. I'm a neurosurgeon that works from Salford. And you've heard a number of technical talks. This is going to be a very practical talk, trying to illustrate to you perhaps where day-to-day clinicians are in their understanding of numbers, statistics, association, and perhaps describe to you, hopefully simply, my journey from using associations to perhaps thinking about causation and effect. And a lot of this work most recently has been done with Carlo, who's been dragging me into the statistical world. I think it's important to start off with that I introduce you to my world. I'm going to just try and introduce you to my world. And on a day-to-day basis, I would look after patients with a subarachnoid hemorrhage, which is a type of stroke. And perhaps about 5,000 patients in the UK would experience this disease. And most of it can be attributed to a weakness of one of the blood vessels of the brain, which gives way. And I tend to spend not an insignificant amount of time trying to fix it, like you can see in this video. Whilst this is all dramatic and exciting, actually, a lot of my day is spent looking after patients, and my patients generally spend about 2 weeks in hospital. And apart from the initial period where the critical steps of diagnosis and treating the aneurysm so that it doesn't bleed again, during their 2-week course, patients experience a number of problems that stop them from making their optimal outcome. And for me, the important thing is that I need to get as many of my patients home and well as possible. And in doing so, you have to understand a little bit about the disease, and perhaps some of this really relates also to some of the analysis that I'm going to show. And so the data table on the left of the screen represents data from the UK and Ireland subarachnoid hemorrhage data set. There are probably about 14 contributing neurosurgical centers from around the country. And this is a summary of the data of the demographics, the injury severity, the complications that patients experience, and their outcomes. And the first thing I'd like to say is that subarachnoid hemorrhage is a heterogeneous disease. And there are a number of clinical scales that we use to measure injury severity, and they are WFNS, which is the World Federation of Neurosurgical's grading system, and the Fisher grade, which is a radiological scale. The clinical scale really describes patients in grade 1 who might be alert and orientated, but also patients that are more severely injured in grade 4 and 5. And these patients typically would present in a coma and would need treatment on intensive care. And the radiological scale is essentially a 4-point scale that describes more and more blood in the head with increasing number. We also measure outcome in a very specified way. Most neurosurgical outcomes are measured according to this scale initially presented in the 1970s. It's a 5-point ordinal scale that's called the Glasgow Outcome Score, and it ranges from death to good recovery. This scale can be dichotomized, and I'll be using the dichotomized version in my analysis a little bit later. And it's dichotomized into favorable outcome, which covers moderate disability and severe moderate disability and good recovery, and unfavorable outcome, which covers severe disability, persistent vegetative state, and death. And in addition to injury severity and outcome, I suppose the next thing that's important just to recognize for this presentation is that patients experience complications. I've already mentioned rebleed, which is critical, but patients also experience a condition called hydrocephalus, and they also experience a condition called delayed cerebral ischemia. And relevant to this talk, I'm going to talk about hydrocephalus. This is a condition in which the fluid spaces in the brain gradually build up fluid, partly because the fluid can no longer drain because of the hemorrhage. When these fluid spaces build up over time, the pressure inside the brain and the head goes up. And as a result, patients can deteriorate clinically and become comatose. And if we don't act as clinicians, can ultimately lead to death. As a neurosurgeon, I would treat this condition by putting a small tube into the fluid spaces of the brain. As you can see in this diagram here, there's a small tube which comes in through the skull, through the brain, into the fluid spaces of the brain. And then that is then tunneled under the skin and brought to the outside into an external drainage chamber. And this procedure is called an external ventricular drain. And this happens in perhaps a third of my patients. So we set up the UK and Ireland database in about 2011, and it was a collaboration between 5 centres initially, and by 2017 we'd accumulated probably over 5,000 data points on patients' journeys through outlining their journeys over many hospitals in the UK. And at that time, we were using it purely as a data set for audit and benchmarking. But because we'd got this large number of data points, we thought that it would be appropriate to consider adding to the literature with regard to risk prediction modeling. And we published this predictors of outcome in aneurysmal subarachnoid hemorrhage paper in stroke. And actually, I was quite pleased with myself at the time, because stroke is quite a good journal. And as a clinician, to get a paper in this journal was quite an achievement. But actually, looking back now, knowing what I know and having been nudged into the right way by Carlo, I probably have to admit that I think the main reason the paper got into stroke was actually we were analyzing a really large data set, and there aren't many data sets of this size in the country on this disease. And really, looking back methodologically, I hadn't used the right outcome. We'd done no internal or external validation. We hadn't really considered missing data properly. And that's before we incorporate statistical technology of considering multiple interactions, for example. And this was brought, I suppose, front and center in my mind when the year following, in the British Medical Journal, this paper from a multinational collaboration was published. Now, these guys used a large data set also. It was multi-center. They'd got their variable selection absolutely right. They used outcome at 3 months, which is a much more valid outcome than outcome at discharge. They'd thought about non-linear interactions with outcome and adjusted for those. They'd done internal validation, of course, but I suppose most importantly for model stability and transferability, they had done an external validation in a data set from a geographically distinct and a separate healthcare system, suggesting actually they ticked all the boxes, almost all the boxes for how a good prediction model should be developed and validated. I suppose because we'd got this big data set, we were trying to improve on the model. We were trying to pick at perhaps the deficiency in these studies, in this study. And it's important to note that most of the data that they used came from randomized controlled trial data, as opposed to data from observational studies. Their data was from the 90s and the early 2000s. And so it was from an era gone by, and they hadn't really taken account time in their analysis. From the 90s to 2010, there'd been a real significant shift in how patients were treated. So their observations may not be valid valid now. And they also hadn't accounted for multiple interactions. And their model was perhaps based on really select admission factors. And so in my efforts and in my thoughts of how I might go about improving it, I set about trying to draw out what I thought was happening to my patients and draw out my patient journey, essentially. And once I'd drawn out this diagram of factors that I thought were associated with outcome, I realized that actually my patients, there were a number of landmarks in my patient's journey, whether it was time or whether it was an event. And the thing that the authors in the BMJ paper had done was actually use information up to the point of the landmark of treatment. But looking back at my diagram, I found the diagram incredibly useful. What they had missed out on is two really important factors that I had considered important in outcome prediction, at least for my patients. The first we've touched on, and you've seen actively, preoperative rebleed. Whole neurosurgical services are developed around the prevention of a preoperative rebleed. Sometimes we don't get to the patient quick enough to treat their aneurysm to stop them from rebleeding. And I know that the natural history associated with a preoperative rebleed is disastrous. I can go from a well patient who is GCS 15, so-called WFNS grade 1 subarachnoid hemorrhage, who has a 90% probability of getting home, to a WFNS 5 patient in the blink of an eye who has a 10% probability of going home. So I know that that's associated with a poor outcome. And I've also touched on the potential impact of putting in an external ventricular drain. I told you that it's a life-saving procedure, so I would assume that actually those people in whom I've put an external ventricular drain might be at least improved in terms of their outcome, given that there was what I thought was going to be a positive intervention. And so using this additional information drawn from this graphical representation, I then went back to my data set. By this time, the data set had grown. We've got 15,000 patients, which we pared down to just over 11,000. I'd got to grips with multiple imputation by this stage, and I could make sure that I wasn't losing any power because of missing data. I'd realized that I'd got a better outcome, and although I'm not quite to grips with interpreting ordinal regression, I stuck to binary logistic regression, and I used a dichotomized Glasgow outcome scale at 3 months. And I built then on what the Sahit collaborators used in the BMJ paper and added the early complications, which was a rebleed, and the early interventions, which was an external ventricular drain. This time I did do some model discrimination and calibration and some internal validation. And so these are the preliminary results. And here, by adding the covariates of early rebleed and external ventricular drain, you can see that they are negatively associated with a favorable outcome. And by adding these covariates, they do improve the model discrimination, and they didn't change the model calibration significantly from before, suggesting at least I've got a better fitting model now with these two additional covariates. I was quite pleased that I had potentially improved on the Sahit model at this point, and was initially thinking of how I might externally validate it to show model stability. But looking at the data closely, I thought, why is EVD associated with a negative outcome? This is something that, you know, I do because I think it improves outcome. And although we were always going to think about multiple interactions, this came further on in my mind, partly because I was trying to explain why EVD was associated with negative outcome. And from a clinical standpoint, before I'd looked at the data, I was thinking, actually, I think EVDs probably have a very different effect depending on grade. In that I think it improves outcome in patients that present in coma, because it's a good thing to try and improve brain physiology, which is what I thought an EVD was doing. And yet it probably has a worse outcome for patients that present really well, because I've got to have a really good reason to put in something that goes through the brain in somebody that's really well. And so I thought that it was the balance of those two factors tipping in favor of the fact that EVD was causing perhaps was associated with a poor outcome in good grade patients, that was tipping the balance, showing the overall negative effect that you see in the EVD. And so we did try and fit the model with interactions. And again, if I'm honest, interpreting these coefficients with regard to the interactions, I still find difficult. And whilst Carlo explained it to me, I still didn't understand it afterwards. And it was only until I plotted out the probabilities by grade and by intervention that actually some of what I was thinking about was borne out, in that the probability of an unfavorable outcome was much higher proportionately in patients that were presenting in good grade compared to they were presenting in poor grade. And actually, it appears that putting in an external ventricular drain doesn't really change outcomes in patients that are presenting in poor grade. Yet putting in an external ventricular drain somehow really does cause a big difference in outcome in patients that present initially well. And I suppose if I was writing a paper and starting a discussion, I would probably say something like, we've observed that an EVD is associated with a negative outcome, and that this negative outcome depends according to the grade of presentation. And then if I was then, because it's clinicians, you always have to seem to add in something in the summary to say you're going to make it better. And if I was then to say, well, how would I make it better? I would be thinking, well, actually, I'd really want to be testing the effect of an EVD on outcome. And actually, the path of least resistance in my mind would be, well, I'll test it in a randomized controlled trial. If you ask me to design a randomized controlled trial to test the effect of an EVD, it's actually feels pretty formulaic. It would be fairly easy to do, except for I wouldn't get any of my colleagues in any sort of equipoise randomizing to this, because as I'd outlined, EVD is a life-saving procedure, and there is I wouldn't do it. And so either we're in a situation where we maintain the status quo and just do what we're doing and accept that EVD is associated with negative effects, or we try and perhaps understand it better. And of course, pushed by Carlo, again, we started thinking, and the first thing I thought is, why is it that as a clinician I rush to a randomized trial? And what is it about randomization that is so good? And from my perspective, I suppose that the thing that the reason why I buy into the randomization process is that it deals with confounders invisibly. I can't see all those things that I can't see is dealt with by the randomization process, allocation of treatment versus control. And the other thing is that as a clinician, and I don't really know why, we just assume that it's good. So in order to analyze this in order to analyze or try and study the effect of EVD question using observational data, it seemed to me that actually I need to make the confounders really visible. And I also need my colleagues to accept the confounders. And having messed around and sketched that diagram to help me with improving risk prediction, I actually set about drawing a diagram that I now understand to be a causal diagram or a directed acyclic graph. And I haven't quite worked out which category, according to Professor Dawid's talk this morning, that my diagram falls into. But this is, I suppose, a representation of my expert knowledge on in terms of testing an EVD on outcome. And here, what I'm doing is describing what I think are the relevant factors with regard to outcome based on my knowledge in the literature. And I'm also describing the factors relevant to how a patient gets an external ventricular drain. What causes me and my colleagues to put in an external drain? And I think by actually addressing both of those issues, I can then, perhaps even simply through using propensity score analysis, analyze the effect of EVD on outcome. Now, by this diagram, I think I've answered one bit of it in that I've made my confounders visible, but actually I still need the acceptance of my colleagues. And so the next thing I did was I took this diagram to my colleagues around the country and sat with them and asked them why they put in external ventricular drains and told them why I was doing what I was doing. And so probably the diagram that you now see on the left is the third iteration of this. And you can see that they've added to my thoughts, and I agree with them. We have an internal agreement between at least 5 neurosurgeons around the country. We've got the beginnings of inclusion-exclusion criteria, and we've also got a landmark for where we think this whole diagram is applicable to. And somebody else agreed with me as well, and that somebody's just given me funding, soft money, albeit, to see if we can test this by collecting the data that we don't have. And so if Carlo decides to retire and return and retire again next year, perhaps I can come back next year and tell you the results of my study. I think I'm going to stop there. Carlo, I hope you enjoy your retirement, but not so much, because I value our Thursday afternoon and Sunday afternoon chats. You've taught me a lot. And I think the best thing about our collaboration is the fact that you've dragged me into trying to learn your language, and I hope I've dragged you into trying to learn my language. And I think that that's where that's why the collaboration in my mind has been so enjoyable and successful. And thank you.
Thank you. Does anyone have any questions? Oh,
yes, thank you. Thank you very much. Yes, I think both of us learned a lot from the other. What's a beautiful example, your talk of a partnership of a dialogue between two cultures, and specifically the medical culture, and a very important problem, and statistical causality. Also, I think you mentioned important points that did not pop up today. The importance of causal inference when you cannot do an experimental study. You have said that very clearly, and you have to rely on real world data. Also, there are situations in which you can do an experimental study, but you'd better first do a causal inference study to get information in order to make a better design study. I want to say the last thing is, you also mentioned interaction. There is a large literature on causative interaction. There is only one point. It's not easy in an observational study. Well, it's not straightforward to interpret a statistical interaction, such as the one we saw in your output, in causative terms. That is, to interpret it as saying, well, this is evidence that EBD can be good for some patients and less good or even adverse for other patients. There are some things to, this is our next work, actually.
Yeah, so perhaps the language is a little bit clumsy in that. I suppose it was the observation was the impetus to test the effect rather than rely on the probabilities and associations.
I think you said exactly what you should have said. I mean, you start from what you said, from the statistical interaction. Only I know, because we have discussed, that your data point to a true, as far as I can see, interaction. And hence, I think that your study is a big motivation for collecting further data and clarifying this.
Yeah.
Only as a causalist, there are a few things to I mean, you basically, in order to be more precise, you have to collect data on hydrocephalus.
Agreed. I should have highlighted that those boxes in red were unobserved variables.
I think it was perfect.
That we were going to collect more data on. Yeah.
Thank you.
Thank you.
Does it ultimately require an RCT though? You know, to convince clinicians to actually think about these things?
Well, yeah.
Matt, I think you're absolutely right. But
you're building the evidence.
Yeah, exactly that. I think if you presented a clinician with a randomized controlled trial, they would accept it, even though there would be, even though that the randomized controlled trial might have problems. I think clinicians understand randomized controlled trials and their mechanism and so on and so forth.
This is still new.
Exactly. They don't understand this process, and that's why thinking about randomized trials and why as a clinician I use them and accept them. I've almost had to translate that into, well, what do I need to do with the observational data and the DAGs to get the same level of acceptance? Because I don't want to be in a position in a year where we have convincing data one way or the other, and yet then not have the medical community accept it because they've not started by accepting the causal DAG.
Yeah.
And I suppose that's my challenge over this. Thank you.
Yeah. Thank you. Tracy.
It kind of goes on from what you were saying there around you as a clinician have been on a journey to understand causal inference. Is a responsibility for us statisticians to teach stats better to clinicians, that we start earlier by saying, yeah, RCTs are good in certain circumstances, but observational data might be what you have to use, and it can be appropriate.
So I think that's absolutely right, because it's much more available.
Yeah.
Medical students use it in their APEP projects day in and day out. clinicians are the key to the causal DAG because it's the representation of what they understand and know and see. And so absolutely it should be introduced early. And actually, you know, it's probably easier, I think, for a clinician to grapple with a causal DAG because that's what they do. I mean, it takes a bit of time to put your assumptions down on paper in a number of iterations, but once you get going, it's actually not bad.
Okay.
Thank you.
Thank you. I think we're breaking now for coffee. Thank you, everyone.
I'm Hui Guo from Center for Biostatistics, one of the colleagues with Professor Carlo Berzuini. Today, I'm going to talk about interval causal null hypothesis testing in Bayesian Mendelian randomization, ternary decision rules, and loss function calibration. I will first talk briefly about frequentist approach. Basically, there are two hypotheses, null hypothesis as against the alternative hypothesis. In the null hypothesis, we are testing whether beta is equal to 0. So beta is any kind of parameters for interest, for example, causal effect of one variable on the other variable, or if we're talking about the efficacy of a specific drug on specific disease. And then we'll be looking at p-value. So p-value is less than 0.05, we reject the null hypothesis and conclude that beta is not equal to 0. But we do have problems by using point null hypothesis testing. First, it only quantifies evidence under the null hypothesis. Here we're looking at the p-value. By definition, p-value is defined under the null hypothesis. So we're not really sure about the evidence of the alternative hypothesis. Second problem is it's often too restrictive for real studies. If in a clinical trial, we would like to investigate efficacy of a drug compared to placebo, clinicians are often looking at a range of values of the efficacy or the difference between the drug and the placebo on their effect in disease risk. What we're going to do is we're trying to define an interval null hypothesis as against point hypothesis. Now, we can see beta in the null hypothesis is no longer a single value, but a range from -t to t. So t can take a small positive value. This interval in the null hypothesis can take values in that specific small interval. And the alternative hypothesis now becomes that beta is not within that range. This idea was initiated by other researchers, for example, in Krushki in 2018, and they call this region of practical equivalence. In addition to this, we're going to take a Bayesian approach to hypothesis testing because the relative level of evidence for both the hypotheses can be quantified. That is one of the advantages of using Bayesian approach. The second concept I would like to introduce very briefly is Mendelian randomization. This approach borrows the idea that our genotypes are inherited from our parents at random. If we can find some genetic variants, they are associated with exposure, and if these genetic variants are independent of confounders and only affect the outcome through the exposure, we'll be able to sidestep the issue of confounding. And then we can make the causal inference between exposure and outcome. These genetic variants are called instruments. Once we found the instruments, we will be able to carry out Mendelian randomization analysis. This approach will require two association studies. The first one is called IV exposure, looking at the genetic instruments and exposure association. And the second study is on genetic variants or instruments and outcome association. If there is no overlapping participants in the two studies, and then we can carry out two-sample Mendelian randomization. But if we have a single study that have all the measures, including the instruments, exposure, and outcome, we can carry out a one-sample Mendelian randomization instead. But in reality, the situations are far more complex. For example, some but not all participants were enrolled in both association studies. This becomes more common at a population level study like the UK Biobank. Some of the participants may well be enrolled in other studies. That's why we're looking at potentially overlapping participants in multiple studies. Second, disease mechanisms are complex as well. We cannot just assume there is only one causal risk factor for disease. And we cannot assume either there is only single causal pathway, and not to mention comorbidity and other factors. A single example here, this is published in 2020 with our former PhD student and with Carlo. We potentially look at the multiple instrumental variables Z1 up to Z3, and 3 exposures X1 up to X3, confounders C, and the outcome Y. If you wish to add more outcomes, this is still achievable. In this very simple case scenario, we can easily find there are multiple causal pathways because X2 can potentially cause Y and X3 can potentially cause Y as well, and X1. Also, if we look at instrumental variables Z2, basically there are 2 pathways through X2 and X3. In this very simple model, we can tell that within Mendelian randomization is far more complex than one would expect it. And this is a second example. We have many instruments from Z1 up to Zj, 1 exposure, 1 outcome, and confounder U. Here, our interest beta is a causal effect of X on Y. These are basically how we set up our Bayesian model. In this case, we assume that they observed confounders from a normal distribution on X, condition on the instruments and confounders from a normal distribution as well. And Y is a binary, so that's why it's from a Bernoulli distribution. Now I move on to causal discovery decision rule based on posterior odds, ternary decision. Let me define 2 variables. V0, which is a percentage of posterior samples of beta falling inside that tiny null range from -t to t. And V1 is percentage of posterior samples of beta falling outside that range. Then we can define our causal discovery decision rule, which was adapted from a paper published in 2018. If the ratio of V0 and V1 is greater than 10, then we accept the null hypothesis with confidence. If this ratio is less than 0.1, then we accept the alternative hypothesis and claim a causal discovery with confidence. Anything in between, we say there is uncertain evidence of a causal discovery. Obviously, these thresholds 10, 0.1 are arbitrary. For researchers, when dealing with real case scenarios, you might wish to select different threshold for purpose. Once we have a ternary decision rule, how we are going to calibrate such decision. Here we use expected loss to actually calibrate the hypothesis test decision rule. Now there are 6 different case scenarios. For beta being equal to 0 and beta being non-zero. When beta is equal to 0, we have 3 case scenarios. If we accept the null hypothesis with confidence, we lose nothing, so loss is equal to 0. If we accept the alternative hypothesis with confidence and we completely lost, the loss is 1. But if we come up with uncertain outcome, when beta is equal to 0, we set the loss being equal to A. Similarly, we can set the same loss when beta is equal to beta star, which is non-zero, for the 3 different scenarios. Here, A is between 0 and 1 because it cannot be greater than 1 and it cannot be less than 0. Then we can compute the expected loss in this function. Here we notice that we only considered 4 different case scenarios because we don't have to consider the situations when loss is equal to 0 because it does not contribute to the expected loss. When beta is equal to 0, we only consider uncertain outcome and also consider when the alternative hypothesis is accepted with confidence. And similarly for beta being equal to non-zero. We've done some simulation experiments, and here I'm just going to show you the performance of our approach as compared to classic Mendelian randomization based on loss function. This is the results when beta is equal to 0. And we're considering 9 different configurations according to different missing rate and different instrument strength. Missing rate I did not mention in the model, but actually we did consider about the overlapping individuals from 2 studies. Within each panel, the vertical axis stands for loss. The front horizontal axis is the value for t, because we allow for different values or different ranges values for that null interval. And also we set the loss A to be varying from 0 to 0.6. The gray bar on the top is from the classic Mendelian randomization because it does not depend on the value of t, because this is point null hypothesis, not the interval null hypothesis, does not depend on value of t. And also it does not depend on A because it's a binary decision. That's why it's a completely flat curve. And for the colored curve underneath, they are actually from our Bayesian approach by using ternary decision and interval null hypothesis. We'll see here almost uniformly our curve, the colored curve, is under the flat gray curve, which means that our approach outperforms the classic Mendelian randomization. When the parameter beta is equal to 0.3, so that's the true causal effect being equal to 0.3, and we observed very similar pattern, and we can conclude that in our simulation experiment, Bayesian Mendelian randomization outperforms classic Mendelian randomization. Now, I'm going to give a real example. That's what we actually studied for a causal effect of obesity and juvenile myocardial infarction. So we have multiple instruments. In this case scenario, we have 360 instruments, and BMI is exposure, JMI, juvenile myocardial infarction, is the outcome. We considered both observed and unobserved confounders. This study has data of 521 Italian patients who had acute myocardial infarction aged 40 to 45 between 1996 and 2002. Here we use the BMI as a proxy of pre-JMI obesity level. So this is what we get. That's the estimated causal effect, the distribution of it. It's not difficult to see that the vast majority of the estimated causal effect, or the posterior of beta, is greater than 0. If we compute posterior mean of estimated causal effect, that's 0.3. And 95% credible interval is from 0.096 to 0.55, which does not include 0, which means that we will be rejecting the null hypothesis if we use this standard. However, if we compute the ratio of V0, V1, that value lies between 0.1 and 10. By using different value of t from 0.02 to 0.08, but from all the values we tried, the ratio of V0, V1 is still within that range, which means there is uncertain evidence for causal effect of genetic induced changes in obesity on JMI. To summarize, we introduced ternary decision rule to Bayesian Mendelian randomization. The uncertainty outcome reduces chances of placing undue confidence in a hypothesis that is only weakly supported from the data. In this BMI-JMI study, despite that 95% credible interval did not contain 0, the evidence for causal effect of obesity on JMI was uncertain. And we also show that the decision rule can be calibrated by a loss function. And also in our simulation experiment, our approach outperforms standard Mendelian randomization on expected loss, which may be due to lack of accommodating the uncertainty of decisions in the latter. This is preliminary results we have, but I would see there are lots of room for expansion or for improvement. Now I've listed 4 references, but in particular, I would like to highlight the second reference because that's the paper we already submitted. That's relevant to my talk today, and hopefully it will be published and shared with the public very, very soon. Finally, I would like to say a huge thank you to Carlo. I'm indebted to you for all the great research discussion and obviously in coffee shops. I hope you enjoy your retirement, Carlo, and keep in touch. Thank you.
Any questions, Carlo?
Yeah, about this, one referee asked Hui and myself why we did not mention the bias factor as a way of comparing null, the interval null with the alternative. Actually, at the beginning, we didn't know how, did we? We didn't know how to answer, but then we found out that we had not a formal proof, basically, that the way we compute that ratio, posterior odds ratio, as the, what's the proportion of the times in which the beta falls in the interval, and we do it with an important sampling procedure, which is particularly efficient, is asymptotically is a simulation consistent estimator of a Bayes factor. So actually, we are using the Bayes factor, and so I would say that this will also inherit the problems Bayes factor sensitivity to the prior. Anyway, we can't have everything in life.
Any other questions? All right. So now I think we could potentially move on to the next stage. So Carlo, you know that there's some strikes going on. So
Yeah.
that's why some people cannot attend in person today,
Yeah.
but they would really be keen to send their good wishes to you. So now let's see what they say.
Just a very short video to thank you, Carlo, for all the work and thought and creativity and time that you put together on starting a wonderful research program on Bayesian computational modeling of pain perception. Your interest, your enthusiasm, your support, and your belief in the project made a lot of difference. Thank you very much for this. It wouldn't have happened without you. We're now looking at translating the insights from this model to a real difference in patient healthcare. I wish you the best for your retirement, and sorry I can't be there in person.
Hello. For those who don't know me, I'm Andy, one of Hui's predecessors as leader of the Centre for Biostatistics in Manchester. I'm honoured and delighted to be asked to say a few words to mark Carlo's retirement. First of all, I should say how sorry I am not to have been able to join the sessions earlier. I've no doubt they will have been excellent. informative and entertaining presentations covering a variety of the topics that Carlo has delved into so successfully during his stellar career. And it has been a career of the highest caliber. Carlo joined us back in 2012 as part of the then Dean's Project Diamond, an ambitious initiative to bring the very best to Manchester. His work on sequential Markov chain Monte Carlo had revolutionized the applicability of Bayesian inference. He's continued to innovate the concepts of causal inference in general and the methods of Mendelian randomization in particular. It was quite daunting to find myself, as a senior lecturer new to the role of centre lead, suddenly responsible for conducting Carlo's annual performance and development review. I'd just like to thank you publicly, Carlo, for making that process not only painless, but positively educational. I always enjoyed them. Importantly, our centre's aim has been to lead methodological research motivated by the types of research studies supported by the faculty, not to undertake statistical research for its own sake. Whilst Carlo's work often leads to statistically, mathematically elegant solutions, it always has at its core a clear aim to find a solution to a practical question. Finding interpretable and meaningful results has been a consistent hallmark of Carlo's collaborations. I'm sure that H's presentation earlier will have demonstrated a recent and ongoing example of how Carlo collaborates with clinicians to find practical solutions. I've had the privilege of observing from a distance as Carlo rapidly gained an understanding and appreciation of the pathology, treatment options, and clinical context of subarachnoid hemorrhage, far beyond anything I'd picked up over many more years. This has been matched only by H's similarly rapid assimilation of sophisticated statistical modelling and the underpinning statistical conceptualisation. It's a perfect example of what becomes possible with interdisciplinary collaboration, and of course, with two planet-sized brains. It would be remiss not to mention Carlo's deeply philosophical approach to his statistical work, and it's only fair to acknowledge that it hasn't always been easy to keep up with his train of thought. If anyone's feeling up to the challenge, though, I'd recommend you to ask Carlo later to explain his solution to the clearly statistical challenge of time travel, as given to some very confused-looking staff during a Christmas dinner a few years ago. I'll just finish by sharing my delight that Carlo has agreed to stay on in an emeritus capacity, and I look forward to continuing to learn from him for many years to come. And if all has gone to plan, I hope to see many of you in the bar in a few minutes' time. Thank you.